We are now going back to premutation involvement, FXTAS and beyond. And then we'll all stop at about quarter two to open it for questions. So on the National Fragile X Foundation website and in many publications, you'll hear about Fragile X-associated disorders, including Fragile X syndrome, FXPOI, and FXTAS. And every time I see that, I get really angry because there are many more problems than just FXTAS and FXPOI and Fragile X syndrome. Particularly in premutation carriers, it involves a whole range of developmental, behavioral, emotional, endocrine, and neurological problems that are not FXTAS and FXPOI. And so I think that clinicians have to be aware of the broad spectrum of problems, and even though the majority of carriers do not have developmental problems, in fact, I find carriers to be very bright, driven. Sometimes, some of the families that come in, moms can be on the obsessive and anxious side, but typically are very successful in life. I see a lot of doctors, I see a lot of lawyers, I see a lot of clergymen, people who are very passionate about their religion, rabbis and priests and other people. Actually, the Mennonite population in the U.S. Has a number of carriers that came over and established very large pedigrees. And, these were people who were passionate about their religion. So carriers are also very common in the general population, more common than those with the full mutation. And their problems are usually milder than what we see in Fragile X syndrome, even those that have some developmental problems. And the problems can be milder except in aging, and I'll show you a bit more about FXTAS. So I also want to talk about some of the benefits of having the premutation. I've said for a number of years that I think premutation carriers can have a higher IQ than the general population, but I finally realized that maybe just smart people come and see me. So I probably have a biased sample. But great verbal abilities combined with a high drive of achievement can lead to high education levels. And one of the papers that we published with Jim Grigsby, I think 40% had either an MD, PhD, or a master's degree. And so we had to go, in order to match for degrees of education, we had to go to the emeritus faculty at UC Davis to be able to match for IQ and age. So many very successful people have had the premutation. So there are strengths associated with the premutation. Reaction time in some studies of women with the premutation was better than controls. This is some data published by Goodrich and others, and for some reason it doesn't show on the bottom, but the premutation carriers had a faster reaction time on some of these computerized tasks. And then just to remind you that the premutation is associated with excess message and usually normal levels of protein, but at the upper end of the premutation, the levels can be down. And the variability in terms of the prevalence has to do in what country individuals were studied. And actually Israel and Tunisia, I think, have the highest level of premutation carriers. In one study at Israel, it was as high as 1 in 113 women in Israel had the premutation, and in Tunisia, I think it was as high as 1 in 40. So I think those are founder effect populations that are influenced by that. So again, we're going to kind of go over some of these different types of involvements, and let me just give you a historical perspective. I also want to point out again that there can be enhanced cell death in premutation neurons in culture, and this is a reflection of their vulnerability, and I especially worry about environmental toxins. Any sort of trauma, as in seizures, can be traumatic to the central nervous system. Oxidative stress is a problem in carriers related to mitochondrial infection. And I think that carriers are more vulnerable to second genetic hits. And we did one study that we published last year by Lozano et al. In Journal of Neurodevelopmental Disorders, that 20% of those with the premutation who had autism or intellectual disability, and we took a group of 50 that met those criteria, had a second genetic hit or a copy number variant that was thought to lead to developmental problems. And it could be that subtle copy number variants in someone without the premutation may not manifest. However, in combination with the premutation, there may be a synergistic effect. So we're in the process of looking at that in more detail. You have heard a lot about the molecular type of dysregulation from Gris, and she explained it in much greater detail than I ever could. I'm married to a molecular biologist who worked with Gris, so I hear this every night, you know. So I've gradually learned some about chronic DNA damage repair, but it's hard when you hear it, I think, for the first time. But I also worry about environmental toxicity, and I think that the premutation is a vulnerable group to different types of environmental toxicity. For instance, just smoking. If you are a smoker, it's been shown that your risk for primary ovarian insufficiency, or FXTAS, goes up significantly, and FXTAS will occur at a younger age. And FXTAS is actually a manifestation of toxicity to the ovum itself. Many individuals have developed neurological symptoms a month or two after undergoing a prolonged general anesthesia. And there's a lot of literature about CNS toxicity from anesthesia. You can Google this. Anesthetics are toxic. It manifests more when you're older. But multiple general anesthesia, even in the general population in pediatric age group, that's shown to be related to cognitive deficits. So it's not surprising that some of the problems of FXTAS can be precipitated by the whole process of surgery. I mean, surgery itself is stressful, and I'm sure enhances oxidative stress, but the anesthetic effect can be toxic. I've had many patients that have been chronic alcoholics and have had fairly massive white matter disease. I had one patient who was a young man after participating in the, it wasn't the Vietnam War, but it was the Korean War, who had about a 2 or 3 month period of using cocaine, and then the military physicians put him on methadone maintenance, but they left him on methadone maintenance for 40 years and didn't take him off. And when I saw him, he was in his early 50s, or actually late 50s, and he had just massive white matter disease throughout his brain, and I'm pretty certain it was related to the methadone, because there's a fair amount of literature about white matter disease with methadone. I also worry about opioids and individuals who have chronic pain, particularly neuropathic pain, and who go to pain clinics and get put on opioids and then become addicted to opioids and stay on them for a prolonged period of time. So I think we have to be careful about all kinds of environmental toxicity. I had one guy who I couldn't figure out. His CGG repeat was in the 80s, and he developed FXTAS in his mid-50s, and he ate well, he exercised well, he took care of all of his medical problems, didn't have hypertension. And he did say, well, I do have a hobby where I'm a woodworker and I breathe varathane fumes all day long. And I think that could be toxic to the brain too. So I encouraged him to wear a mask and do his varathaning outside. So you'd be surprised how many exposures can occur in the general population. You just have to ask specifically. Well, we went over that in detail. But I want to show you kind of the influence of environmental aspects and mitochondrial dysfunction. We have published a couple of papers now about mitochondrial dysfunction in individuals with FXTAS, and people with FXTAS get weaker and weaker, and mitochondrial function studies can be quite problematic. But this can occur even in premutation carriers before they develop FXTAS, not as severe as what we see in FXTAS, but now we're particularly interested in psychiatric problems and how that relates to mitochondrial dysfunction. And we are seeing significant mitochondrial problems in individuals that suffer from severe depression. There actually is a literature linking depression and mitochondrial dysfunction, and I think we're definitely seeing that. We haven't published on that yet, but we definitely are seeing that. So mitochondrial dysfunction causes oxidative stress. The mitochondrial are these power engines, if you will, in the cell that produce the energy that keeps the neuron moving and active. And if it's out of tune, or if some of the enzymes don't work well, it produces a lot of oxidative stress, just like an out-of-tuned car produces a lot of exhaust. And we see an increase in oxidative stress, which can cause damage to macromolecules and problems leading to early cell death, as you see down here. The mitochondrial dysfunction can have an influence on both the GABA and the glutamate system, as you see here, and that can relate to inflammation. A variety of things. Infections can stimulate inflammation. Injuries can stimulate inflammation. And this has an effect on neuronal cell signaling and also on mitochondrial function. And then there can be some influence on neurogenesis. Now, everybody wants to enhance neurogenesis in their brains because we do know that brains can improve over time through neurogenesis. We didn't realize that until a few years ago, but this can be very important in aging too. And neurogenesis can be influenced by all of these things. Inflammation, oxidative stress can have a negative impact on neurogenesis. And this accelerated aging with telomere shortening is important. We've published a couple of papers with Ed Jenkins. We see telomere shortening both in Fragile X syndrome and in premutation carriers. So there is evidence that there is enhanced aging through the telomere measurements. And actually, we even know that mindfulness meditation and yoga can improve telomere lengths. So it's not to say that yoga and mindfulness meditation is not helpful, but it can be helpful not only in reducing stress, and maybe that has an impact on oxidative stress, but also on telomere length changes. This hasn't been shown in Fragile X syndrome, but in the general population, it can have some effects on telomere changes. So this is pretty important thinking about how everything interrelates. I just want to say a few things about primary ovarian insufficiency, or FAXPOI. We actually first reported it in 1991, and multiple other centers have documented this. And the most interesting thing about it is there seems to be a U-shaped effect in that the age of menopause seems to be the lowest in this range of 80 to 100 repeats, and then it may not be so low when you get into the upper end of the premutation range, but maybe that's because FMRP starts dropping and may have some influence on the RNA toxicity. But there is a U-shaped effect that seems to be coming out now with the prevalence of psychiatric problems, in that seems to occur mainly in this 80 to 100 CGG repeat range. So you'll see a lot of that in the literature. Now, I showed this yesterday, but let me just go through it again for the newer participants. We published about premutation involvement in boys with Fragile X, with the premutation, depending on whether they presented as the proband in their family. The proband meaning the person identified first who comes to clinic with problems. And so problems are much more apparent in the proband, and you would expect that also in premutation carriers, compared to maybe a sibling identified with the premutation who is not the proband. And here's an example of that. This young boy here is the proband. He's 7, and this one is 6. And the proband presented, and he had autism and ADHD symptoms. They both had pretty similar IQs, but it was on the low end of normal. And the brother here, who is the non-proband, had anxiety and ADHD. So ADHD is increased in the non-proband compared to the controls, but not nearly as high as the proband. Same with ASD. It's rare that you would see an ASD or an autism spectrum disorder in a non-proband. But we published this many years ago now. And 4 years after this picture was taken, I did a follow-up. And here's the follow-up 4 years later. This is the whole family. The youngest brother here did very well. I actually put him on sertraline because of his anxiety, and his social deficits responded very well to sertraline. Mother thought it was a miracle drug. He's now in the normal classroom. He has lots of friends, and he has a normal IQ. He didn't have autism, but he had some mild social deficits when we saw him. The oldest brother, though, had autism, but he did not do well with sertraline. He actually became overactive, so the mother just discontinued it instead of lowering the dose. He developed seizures, but it wasn't treated by the pediatrician until about the 3rd seizure, and then they became more difficult to control. And now he went through a regression, actually, over these 4 years. And now he has much more severe autism and very low verbal abilities. So he's much worse off than what he presented at initially. The grandfather here has FXTAS, and the mom here is a premutation carrier, and her sister has quite a few immune problems. So this is a very interesting family with premutation involvement. Now, premutation neurons in culture do have an increase in burst spikes. 8 to 13% of carriers can have seizures, but you see these spike discharges much more dramatically in premutation carriers compared to control neurons, premutation neurons compared to controls. And actually, allopregnanolone, this GABA A agonist that we're very interested in, can eliminate the spike wave discharges and dramatically help premutation neurons in culture. Now, a lot of people, when we first published on premutation involvement, they were concerned because they just felt that only affected premutations came and saw me. And that's true to a certain extent in that I'm biased, but we try to eliminate the bias by looking at probands versus non-probands. But a better way to eliminate that bias is to do newborn screening. And we did do newborn screening, and we identified a whole cohort of premutation carriers who we followed over time. There are some visual tasks that Susan Rivera's family, a research group, family of researchers, I should say, carries out in our baby study. And that is they do eye tracking studies where they have individuals look at static visual changes where the visual stimuli doesn't move, and dynamic visual stimuli where it does move. And in the static visual stimuli, there's basically no difference between, or no significant difference between premutation carriers in blue here, individuals with a full mutation, and typically developing controls, all aged matched, when looking at static visual images. However, when looking at dynamic visual images, the full mutation deficits compared to controls were published first, and we were very surprised when we added the premutation individuals to the mix, because they initially showed pretty similar deficits as seen in the full mutation individuals. Here is another more recent study, including those individuals that were identified through newborn screening. And these are all babies, and basically this is typically developing. This is a threshold for intensity, threshold contrast for intensity. And what you see is a higher threshold in Fragile X syndrome individuals, and the premutation carriers are in between the typically developing and Fragile X syndrome. So we do see early visual deficits, and we didn't see, when we looked at developmental testing on the Mullen, the premutation carriers are the red here, and the comparison group in newborn screening are the blue. And this is a multi-center newborn screening study that we did with Liz Berry-Kravitz in Chicago, and then the people in North Carolina, Don Bailey's group. This is in press right now. But basically, there wasn't too much change here on the Bolin early learning composite. This is the percentage below average on the early learning composite, but there seems to be now at 30 months some separation developing between the premutation carriers and the controls. This just looks at hyper responsiveness by diagnosis and age. This is an SEQ questionnaire where it seems to be differentiating now between premutation carriers and controls at 30 months, and we hope to continue to follow this cohort. It's been shown in premutation neuron studies that the mitochondrial problems can begin fairly early in premutation neurons, where the mitochondria can move more slowly, and there can be fewer mitochondria. And this just looks at mobile mitochondria premutation compared to controls, and immobile mitochondria. So it is less movement with the premutation mitochondria, and the mitochondria are needed for the dendrites to move and make connections early on in development. Now, whether this has to do with oxidative stress, and whether individuals with the premutation or even full mutation individuals could develop from early use of antioxidants, we're trying to sort out now. In fact, we had some good discussions in the break about that. So psychiatric symptoms are something that premutation women particularly have been studied in detail. Men have been studied less, but there can be problems in men too. But early on, there was a report that there may be higher rates of depression and interpersonal sensitivity. We found higher rates of obsessive-compulsive behavior that actually correlated with messenger RNA levels. It's almost like the increase in message correlated with increase in obsessive-compulsive behavior. Now, having obsessive-compulsive behavior can be good in our society for many different types of work. I would say, especially for molecular biologists, my husband's a little on the obsessive side, but if he wasn't obsessive, he wouldn't get the good results in the laboratory. I'm less obsessive, so it's good he's married to me. But being obsessive is not necessarily bad. It can lead to high achievement, which is maybe why we see such excellent education rate in carriers. So the SCID is a standardized psychiatric measure, and Don Bailey's group showed that major depressive disorder occurred in 43% of the women and panic disorder in under 10%. And our data shows that lifetime mood disorder occurs in those with FXTAS in 65% and in 42% of non-FXTAS premutation carriers. And lifetime anxiety disorder in 52% of those with FXTAS and in 47% in non-FXTAS pre's. So anxiety does seem to get worse with age. And of course, if you're developing some neurological problems, that is enough to make anybody anxious. So we definitely expect to see more anxiety problems as neurological problems develop. But the important thing here is you want to recognize these symptoms and actually treat these symptoms. So whenever I see a kid with Fragile X syndrome, I always ask the mom how she's doing. And some of the mothers just, burst out crying and tell me that they really are under major stress. And so you need to get help for those mothers. We do know that excess anxiety can shrink the brain. And this just shows rates of anxiety on the SCL90 down here. So the more anxiety, this shows right hippocampal volume, the smaller the hippocampus. So worrying, depression, and anxiety actually can shrink the brain. So you don't want your brain to shrink. You want to treat your anxiety. Exercises, I'll show you in a moment, is a great way to treat anxiety, but utilizing SSRIs help with both anxiety and depression, and I would rather treat someone with counseling and an antidepressant medication like an SSRI, which can help with the anxiety or depression and also stimulate neurogenesis. So in many ways, you're taking care of yourself. This is a study of 146 females, 18 of whom have FXTAS compared to age-matched controls, and these are non-FXTAS premutation females compared to age-matched controls. And we see FAXPOI in similar percentages, definitely more than controls, which is what we expected, but I didn't expect that 50% of the women with FXTAS had thyroid problems, usually hypothyroidism. That usually starts quite earlier than FXTAS. Here it's 17%, close to twice as many of controls, but it wasn't significantly different. But we recommend thyroid testing on a regular basis for women with the premutation, particularly if they feel chronic fatigue or lack of energy. Muscle pain is very common. Just in, a quarter of those without FXTAS, but up to 2/3 or 75%, 3/4 with FXTAS, and over 40% have been diagnosed with fibromyalgia. Neuropathy symptoms are very common in non-FXTAS carriers, and of course even more common in those with FXTAS, along with walking problems and along with tremor. But this is just looking at other symptoms. And so for each of these symptom areas, we've gone on and tried to look at a much larger group of premutation carriers compared to controls. And some things that have come out in some of our studies were summarized in Lancet Neurology a couple of years ago. But insomnia is a real common problem in carriers, and I think that the clock genes are dysregulated, not only in Fragile X syndrome, but in carriers. Sleep apnea was actually seen very commonly in those with FXTAS, and it's one of the reasons that we try to rule out with anyone with FXTAS that is going downhill rapidly, because if they have sleep apnea, they are hypoxic at night, and that can kill off neurons. And so we like them treated for their sleep apnea. Another problem, the hearing loss has been reported by others, in addition to those with FXTAS, of course, are likely to have neuropathy, but it can occur even before FXTAS. One thing that's not talked about very much is cardiac arrhythmias. because the inclusions, I'll show you in a moment, can occur all over the body, including the cardiac ganglia and even in cardiac tissue itself. High blood pressure is something that we see in about 60%, and it typically starts in the 30s or 40s or 50s, so well before any problems with FXTAS. Gastroesophageal reflux is quite common. Erectile dysfunction is very common in males well before FXTAS begins, so autonomic dysfunction and development of swallowing problems are pretty common, along with dizzy spells. But migraine headaches are somewhere on here, and that's a common problem too in both males and females, and I think that relates to the mitochondrial dysfunction. So these are all common problems in premutation carriers. So when you think about premutation involvement, FXTAS was defined really in 2003. We described it in 2001, but we developed diagnostic criteria in 2003. So it represents an image of someone with major neurological problems, but minor neurological problems and a variety of other disorders can occur related to the premutation, higher in premutation carriers than controls. And there can also be subtle changes on MRI, whether you look at functional MRI or diffusion tensor imaging changes that can occur throughout life in premutation carriers. And here we have healthy controls here on functional MRI, premutation carriers without FXTAS, and there are some significant differences in how different parts of the brain light up. And then with FXTAS, there's even more constriction in some of the light up. And also, this is looking at gray matter density decreases in premutation carriers, either with FXTAS here in the middle in black, and this is normal in red, and here are premutation carriers without FXTAS. And as you can see, changes can occur in adult life in premutation carriers without FXTAS in terms of gray matter density changes. This is in the vermis of the cerebellum, but subtle changes in diffusion tensor imaging findings in white matter can occur throughout adult life. Here we look at executive function across the lifespan and premutation carriers compared to controls. And here's the decades down here. And this just shows the premutation in black with more significant deficits in the 4th, 5th, and of course in the 6th decade. And this is data from Kim Cornish's lab. And these are in individuals before FXTAS. So we do know that premutation carriers can have executive dysfunction even before the development of FXTAS. And so you start out with the premutation with some vulnerabilities. You can add problems related to environmental toxicity and sometimes adding additional medical problems, particularly if it goes untreated. And I think the addition of these problems can kind of tip the balance towards FXTAS. And so what we're very interested in is trying to eliminate these things that we think can bring FXTAS on more quickly, and think about how to prevent FXTAS, if you will, or at least to keep individuals as healthy as long as possible with the premutation. So we first reported it after seeing this gentleman and 5 other individuals. This is a premutation carrier, and his daughter and her 2 children with Fragile X syndrome who are very high functioning. We first focused on the tremor and ataxia. Then we found the inclusions in the brain of this gentleman who actually died just before I moved from Denver to California, and I took his brain with me and then had our neuropathologist Claudia Greco look at his brain, and I still remember the day she called me and said, "Ooh, there's something really interesting in this brain that I've never seen before." And she was a neuropathologist, and she said this is very unique for this syndrome. So these are inclusions in the nucleus. They're eosinophilic positive, they're tau negative, and synuclein negative, so they look different than other types of inclusions. They can occur throughout the limbic system. There's white matter disease in the brain, in these middle cerebellar peduncles, which is fairly classic for FXTAS. The brain atrophy, this is actually the most dramatic brain atrophy I've ever seen in any patient, FXTAS or no. We have an animal model with the Premutation mouse who develops the inclusions and also develops some tremor. I'll show you what, this is a very bright woman, a gifted woman who has her PhD from MIT. And she was a nun for many years and then a college administrator. And she's had this intention tremor for many years. It's not there at rest. It's only there with movement.
Okay, go ahead.
But it really interfered with her career as a college administrator. And so she had to retire.
You can hold paper.
I can't get the pen down.
So it's even hard for her to get the pen to
Okay, try it with support.
Usually the tremor is worse in your dominant hand, and it can interfere with daily activities like eating and dressing. And the tremor can get worse over time, but in women it can stay quite stable. FXTAS is overall less frequent in women. The FXTAS prevalence increases with age. In men, it's present in about 17% in those in their 50s, 38% in your 60s, 49% in your 70s, and 79% in your 80s, at least from California data that we've published. The MCP sign that I showed you is kind of a classic feature. About 50% of the men with FXTAS can develop dementia. When dementia does occur in women, it's usually associated with Alzheimer's changes, but we think dementia can occur with FXTAS alone. So these are all the problems that can be associated with FXTAS. Definitely you can have Parkinsonian features, and oftentimes it's diagnosed as Parkinson's disease. Cognitive deficits, autonomic dysfunction, psychological features can become much more severe as you develop FXTAS, and peripheral neuropathy and global brain atrophy and white matter disease. So here were the diagnostic criteria that we laid out in 2003. We put the inclusions in post-mortem in 2004. And then a meeting that we had last year, we actually added neuropathy, and we found individuals with FXTAS who have a gray zone or an unmethylated fold. So we've changed the CGG repeat numbers. So it's not just premutation carriers that may develop FXTAS. The majority of individuals with Fragile X syndrome won't develop FXTAS because they don't have elevated message. But the ones that are at risk are the ones that do have elevated message. So the insula can develop white matter disease, seen here. And this is the inside of this brain slice. This is the insula, and it is an area for processing emotions, and also it can influence pain perception. And many individuals with the premutation can develop fibromyalgia and kind of a central pain syndrome, particularly women. So we can see white matter disease in the pons besides the middle cerebellar peduncles, and in the posterior aspect of the corpus callosum with some thinning of the corpus callosum. So, we all go downhill with age, and we're all going to die. But individuals with FXTAS can die a little quicker, so they can go to an accelerated aspect to their disease where they're going downhill faster. Some of these individuals, when we look at the neuropathology, they have Alzheimer's changes or Lewy body dementia, and sometimes other disorders too. We saw one woman who died of multiple sclerosis and FXTAS. So it's possible that maybe FXTAS can kick in other disorders of aging, and the relationship between Alzheimer's and Parkinson's disease and FXTAS really needs to get sorted out by further studies. Many of the women stay very stable with sometimes decades of tremor. Other individuals start telling me that they have foggy thinking and poor memory, and intermittent tremor, and we do an MRI, and their MRI is clean, and oftentimes their neurological exam is clean, but they have some of these symptoms. So are these early stages of FXTAS, or are they pre-FXTAS? So we don't really know, and usually we institute early treatment, as I'll show you in a moment. I just want to point out that we've seen some individuals with the gray zone in FXTAS. We published on one case where the sibling had regular FXTAS and was a premutation carrier, and the brother had just 52 repeats. And so maybe he deleted a few repeats, but he clearly had a gray zone. And then this is the first case where an unmethylated full mutation carrier was diagnosed with FXTAS, and he had a history of alcoholism and a smoker for 30 years, very heavy drinker, 58-year-old. He also had surgery and then develops tremor and ataxia, aggression, hallucinations, urinary incontinence, and he was clearly high functioning and high message level, in addition to Fragile X syndrome. So he had a lot of white matter disease and dilated ventricles, and you can faintly see the middle cerebellar peduncle sign here. It's interesting that he had hallucinations, because we do see sometimes some psychotic thinking in those that have the double hit of high message and low protein. And here's a mosaic male that I followed for many years. He was actively gay with intermittent depression. He was high functioning, and he developed neurological symptoms at age 67. The neurologist in Denver, Deb Hall, felt that this was Parkinson's disease, and I said, I don't think so. I think he has FXTAS, because he had tremor and ataxia. And sure enough, when we did the study of his brain after death at age 77, he had inclusions. So we've seen it in some mosaic individuals also, but definitely high functioning. Here's a gentleman that had a history of Asperger's syndrome, premutation carrier, diagnosed in childhood, but he had a pretty good IQ, but then developed memory and executive function deficits in his late 40s and went downhill with full dementia, tremor and ataxia in his mid-50s. So if you start out with developmental problems and a premutation, are you at risk to get earlier aging? And we don't know the answer to that yet, but it looks like that may be the case. So we did a controlled trial of memantine, which blocks glutamate toxicity. It wasn't helpful for the tremor and ataxia or executive function deficits, but there's a subgroup that we did event-related potentials, and there were definite benefits on the ERP with N400 repetition effects that were much improved compared to placebo on memantine, and many patients say that it was helpful to them, even though it wasn't clinically helpful for the overall group. So cued recall after 1 year improved with memantine compared to placebo. We get everybody exercising because, believe it or not, exercise improves mitochondrial function in your brain besides in your muscles. It increases the size of the hippocampus, improves memory, and boosts BDNF in the hippocampus. It blunts the HPA axis response to stress, so it helps individuals with stress. It improves inflammation, depression, and neuroimmune dysfunction, and it also improves gliosis. which can be more problematic with age. It stimulates telomerase activity, so the lengthening of telomeres, which are shortened in carriers, as we published in 2012. Again, it improves mitochondrial function and biogenesis in both the brain and the muscle, and it reduces vascular endothelial oxidative stress. So it improves even vascular disease in the brain. So everybody should be exercising, particularly when there's good weather like this. So we treat stress and emotional problems like anxiety and depression with SSRIs or SNRIs. If they have pain like fibromyalgia, we usually use Cymbalta. We do a lot of counseling and psychotherapy. We're looking into biofeedback programs that are computerized that can reduce stress, massage therapy, mindfulness meditation, and yoga. We treat high blood pressure. We treat migraines aggressively. We treat thyroid dysfunction. Many individuals are vitamin D deficient. I would say that a lot of people in Norway are vitamin D deficient, particularly if you live in a not so sunny part of Norway. So we treat them with vitamin D, folate, B12. Deficiencies are common. We also recommend antioxidants, as we've discussed before. We try to get them to avoid weight gain because the metabolic syndrome and even type 2 diabetes is quite common when individuals become weaker and are not able to exercise. Allopregnanolone, this natural neurosteroid, GABA-A agonist, eliminates Alzheimer's plaques. So it's being studied now in Alzheimer's disease. It can reduce the spike frequency in premutation neurons that we published in 2012, stimulates neurogenesis, and we've been FDA approved to do an open trial in individuals with FXTAS, but maybe it'll help premutation involvement. So my conclusions are that can be lifelong involvement with premutation carriers. Mitochondrial dysfunction and oxidative stress are key biochemical features. Genetic and environmental lifestyle factors are important for CNS involvement. And the brain is dynamic, and it can respond to lifestyle changes and stimulation of brain function. And this kind of summarizes all the things that I've already said. And this is a good paper in Brain Disorders and Therapy that I hand out to premutation carriers. And I can send it to you, Jan. You can pass it out to carriers here in Norway. But I think there's a lot of things that you can do to significantly lower your risk for FXTAS or other premutation problems. And I think I better end there and answer any questions you have.
Actually, I have a comment. I'm 78, you heard that yesterday, and I have 3 factors that keep me very healthy. 1, I take cod liver oil all year round. 2, I have a border collie who keeps me exercising him for 2 hours every day, so he is my health insurance. And now I've had my intellectual, mental exercise for 2 whole days. So I feel very healthy at the moment, and thank you very much for a very inspiring lecture.
Yeah, you have the secret for staying healthy with age. Absolutely.
Thank you.
I think Jan had a question, yeah.
Yes, first of all, I'm very thankful for your lecture today. In Norway, it's over the years getting much better to diagnose the boys with full mutation. But as many other countries, many of the girls with full mutation it's been diagnosed too late to get help early enough. What signs should the doctors, genetics look for to get diagnosed to the girls early enough?
So what's very important, I think, is once you identify a proband in a Fragile X family, we do cascade testing through the family. And it's been shown that telling family members about whether they have the pre or full, it's better the younger you tell them. You don't want to wait until they are adults or ready to get married. That's a very bad time to tell them. Usually it doesn't make much difference telling them when they're young, and then they can grow up knowing that I'm a carrier just like mom, and it's no big deal. Or we see many women with the full mutation that present with learning disabilities. And so that's easy to identify when you do cascade testing through a family. Although I've had several mothers that are fine with testing their sons, but the child who is doing much better, sometimes a family, it's hard emotionally to hear that more than one individual is affected. So sometimes it takes a family a little while to come around for testing. But I can think of some examples like in one family where the boy was significantly affected with Fragile X. The mother thought the girl was normal. And we said, well, we routinely recommend testing. And the teacher said, oh, there's no problems. She sits in the back room and she doesn't cause any problems. Well, we tested her and she came out with a full mutation. And then we did cognitive testing, and she came out intellectually impaired. So she's sitting in the back of the classroom, not saying anything and not doing anything because she doesn't understand what's going on. And if you didn't actually test and identify and then say, oh, she has the full mutation, we have to figure out what's going on here, and then find the problems, then you can remediate them. But she could have gone through a few years of school and nobody noticed that she's not picking up and that she's intellectually disabled. Because the girls may not be as problematic behaviorally as the boys. Now, some girls are, but most are not. And they can be quiet and shy. We see a lot of selective mutism in girls where they talk at home, but they don't talk in school, or they don't talk when they come to a clinic. And that can occur even in individuals that have normal or close to normal intellectual abilities. So shyness and social anxiety, attentional problems, language delays, these are the kinds of things that you would want to test for. I mean, the general message to physicians is test if there's intellectual disability. Do you test everyone with ADHD? No. But if they hand flap or have huge ears or hyperextensible joints or doing something else that's unusual for just run-of-the-mill normal IQ ADHD, then you might want to think about testing for Fragile X. If they're significantly language delayed and have any features that you think of as being Fragile X, or have a family history of, a brother with intellectual disability, then you would think about testing for Fragile X. So I don't test everybody that's learning disabled or ADHD for Fragile X, but I have a pretty high index of suspicion, although most individuals are diagnosed even before I see them for the ones I see. But I think when you're out there in clinic, you have to be thinking of this constantly. So you do test everyone with autism when you don't know what causes the autism. You don't just say it's idiopathic, because a lot of kids with Fragile X are diagnosed with autism first, and then only when they have DNA testing do they identify Fragile X. So this will become more and more important as new targeted treatments become available. Not that the targeted treatments may not be helpful for autism too, but at least you want to know, what you're treating. And there are many forms of autism too. I could do another lecture about copy number variations and, all the different problems associated with autism. But, I think it's important to have a very high index of suspicion. Now, I think in Norway, neurologists are not testing individuals with tremor and ataxia, and I don't know if they test individuals, women that have early ovarian failure. I don't think so. So you guys got to change that. You know, you got to change that. You got to meet with the OBGYN doctors. So in the U.S., on the East and West Coast, where we're better educated on the East and West Coast, see, so the OBGYN doctors test for these things. But in Middle America, you know, the area that votes Republican, no, I'm just kidding. In Middle America, you know, they're not on it like they should be. So I would say that the neurologists in the U.S. have really picked up the FXTAS banner. I mean, we publish a lot in neurology journals, and they have really gone on and, you know, my husband and I have spoken at neurology conferences, and we publish a lot. So, you know, I have neurologists all the time that email me about how commonly they see FXTAS. But I went to Canada and spoke to a bunch of families, and one family told me, oh, my dad's seen 7 neurologists, and nobody wants to test him for the premutation or FXTAS, even though they know that I have a fragile X son. So I don't know what the problem is in Canada. Maybe they don't read the American journals. I don't know, but it's a much bigger problem in Canada. And, you know, I was just in Stockholm, and the neurologists there at the Karolinska, they're really into FXTAS. They had all kinds of exciting cases to show me, and they had one that, you know, multi-generations in a family with FXTAS, and they were really hot to trot. But that has just been in the last couple years. And, you know, I think that now they're really picking up on it. But I don't know about Norway. I worry a little bit about Norway. So the question has to do in the autism literature. There's a lot written about hyperserotonemia. So the blood levels of serotonin may be high, but that doesn't mean that the levels are high necessarily in the brain. So the studies I show you were PET scanning in the brain, and I think it definitely has to do with age too. So there was both PET scanning and molecular evidence that, you know, the tryptophan metabolites getting from tryptophan to serotonin were all downregulated. Those enzymes were all downregulated, which I think could lead to low serotonin in the brain. And maybe serotonin gets increased in the blood to compensate for that. So that may be one issue. I do think that, you know, I believe the King et al. Study where they looked at citalopram in individuals, you know, 6 to 17 with autism, that there wasn't any significant effect. But that doesn't mean that a subgroup didn't do well, because I can tell you a number of patients that have autism and really severe anxiety, and you put them on an SSRI and they do better. And we're not just talking about the young ones. But I think there's a particular effect in young children that could help to boost language. Now, one issue is I've just got finished writing a grant about the follow-up on sertraline. How long do they need to be on sertraline? Do you need to take them off after a year or so? We don't know. I mean, I have had some that showed later hyperarousal. And we're also doing serotonin alleles, serotonin transporter allelic variants, and also the cytochrome P450 system for metabolizing sertraline, whether they're rapid or slow metabolizers of sertraline, may have to do with how they respond to sertraline initially in our children's study. So we're going to look at that when we analyze the results of the children's study. But, you know, we need to do follow-up, because maybe they need to go off sertraline after a year or after they've really boosted their language. Yeah.
Just, you know, you speak of sleep disturbances, and this is a very common complaint by the patients. Did you substratify or somehow more specify this sign? And secondly, you know, we were just reviewing guidelines for the European Society of Cardiology for genetic testing in arrhythmias, and nobody thinks of testing for FXTAS, you see. So it's not only the neurologists, but it's also these other disciplines where you do now genetic testing quite commonly, and arrhythmias is now a big deal in the genetics community, and nobody thinks of that.
I know, because we've only mentioned it in a couple of papers. The reason why I came to realize that some have arrhythmias is because I like to do MRIs. But if they have a pacemaker in place, I can't do an MRI. So I'm thinking, why do all these guys have pacemakers in place? I'm a pediatrician. Do all old people have pacemakers? And but then we did both mouse and human studies, and I didn't show you the pictures, but in 2011 we reported that the inclusions are all over the mesenteric plexus. They're in the paraspinal area. They're in the adrenal gland. They're in the thyroid. They are in the pericardial ganglia and even in the heart itself. But you think it's hard to get neurologists to pay attention to these things. It's even harder to get cardiologists to pay attention. I'm telling all my patients, give this paper to your cardiologist. And so I've been talking to some cardiologists trying to get them to pay attention to these things, because FMRP, I've had also a handful of individuals with Fragile X syndrome die from sudden death. And, that's from, they can get mitral valve prolapse, and, that could probably predispose them to arrhythmias. But I've had a few that had a sudden cardiac death. Thank God they were not on medication when that happened, or I'd get blamed for it, But there clearly is a conduction problem that is rare in Fragile X syndrome, but it's much more common in the aging, and I think these inclusions are in the pericardial ganglia.
Okay.
So I just want to, this is very important, so it's worth going over time. So I just want to talk about sleep disturbances, because this is very important in development too, because stimuli during the day, that gets consolidated into dendritic spine changes at night. If you don't sleep at night, your dendritic spines don't develop well. So I really push for helping sleep. And particularly in patients with Fragile X, first I'll put them on melatonin, then I'll put them on clonidine, and then I'll go up on the clonidine, because I want kids to sleep. Not only to keep the mother without depression, because she's not sleeping, but to keep the kid well. But there is definitely a sleep disturbance in carriers. And many carriers do not sleep and do nighttime worrying. And, I haven't found the optimal sleep medication, but they have been on many different types. Usually it's a benzo, which is probably helpful, but probably suppresses REM, but I think it's important for many of these individuals to treat them so they sleep, or else their psychiatric symptoms just get worse. But sleep could really help cognition in young kids, so you want to get them sleeping. And they don't sleep. Fragile X kids, autistic kids too, so you want to get all these kids sleeping.